thank you all for turning up. Welcome to our Medical Student Station's second academic event for third years. How to do a grand round. Most of you, I hope, were at the What I Wish I Could Do in third year event last Tuesday. If you weren't there, we'll be putting it up on our website very shortly, so you can catch us there. If you don't know me, my name's Alex. I'm one of the academic events officers this year.
I'm Alicia, I'm the academic event officer.
And our wonderful academic director, Gunny, is there at the front. So without further ado, let's make a start. We're going to have plenty of time to answer any of your questions at the end of the presentation, so I could just ask if you save your questions until then. And I really don't expect for us to be here more than about 30-45 minutes, so we should speed through this. Okay. So this is 2-pack. This is the same slide as what I need third year. A key point about grand rounds is that whilst we're going to give you some tips and show you some pointers based on our experience, and we've done 3 firms, we've done about 6 grand rounds each. All of us who've done third year. Every consultant likes things a little bit differently. So just be aware that if we've said something and your consultant says something different, listen to her or him. And not us. And one specialty I'll draw your attention to now, which do things quite differently, is when you come to your psychiatry grand rounds. There'll be a lot less formal often, so it might be sort of 4 or 5 people sat around a table rather than, and often they'll ask you not to use PowerPoint slides. We can talk a little bit more about that later on. And yeah, so there'll be lots of, like I say, you'll hear lots of different things about grand rounds, but if in doubt, check with your consultants or whoever takes you for your grand round. It's sometimes the registrar. So, if you don't know what a grand round is, hands up if you do know what a grand round is. Okay, that's good, guys. Let's see. So, grand round is one of the oldest forms of medical teaching. This is a grand round hosted by a guy called Dr. Janeway. Who's on chest? Hands up if you're on chest. Chest first. Anyone know what a Janeway lesion is? Did we talk about that yet? No, it's one of the typical medical student things which I'll teach you all about. It's a splinter hemorrhage in the fingernail, which apparently is a sign of endocarditis, but they are stupidly rare, and no one ever actually has them. So basically, in the old days, you'd get a patient who had something interesting, you'd bring them along to a lecture theatre and sit them down, and then all the medical students and doctors in the audience would be able to ask that patient's questions and come down and do examinations, and therefore it would be a sort of teaching experience for the whole hospital community. Your grand rounds aren't quite like that, but the idea is still the same, that you have a patient who has some interesting or typical characteristic, or history, or examination finding, or condition, and you present their case to your peers, and then you're quizzed about it at the end by your consultant. And it is a fantastic teaching opportunity. It's a real opportunity to get to know a particular topic or a particular disease in a lot of detail, and it's also a good opportunity to integrate your history-taking skills, your examination skills, and your data interpretation skills in one clinical setting. So without further ado, Alicia is going to present one of her grand rounds from last year.
Hi guys. So this was one of my abdomen grand rounds. I've given it a title because I like to make grand rounds fun. But it's also because my patient presented twice within the space of a couple of months with a distended abdomen, so I thought it would be useful for my colleagues to learn all the different types of causes for distended abdomen. So I interviewed a 48-year-old gentleman on this ward who presented to A&E saying that his tummy was large and painful. He came in at 7 o'clock and it was revealed that he had a 24-hour history of central abdominal pain and some mild distension. The pain was constant, sharp, severe, and in his umbilical area. It was worse on coughing, touch, walking, but better when he was lying flat. And the distension was a small, tender area, and he also has some general distension across his whole abdomen. So in terms of the history of this, there was no vomiting, there was some sort of vomiting, but no other associated symptoms. So now you do a systemic inquiry. Apart from what I've already mentioned, my patient only had headaches and some arm cramps, but no other red flags, so no weight loss, fever, tiredness. He was diagnosed in 2010 with chronic hepatitis C, which he'd never been treated for, so that's why you call it treatment naive. But he was due to start a treatment program at King's. And these are the 3 medications that he was due to start on when I saw him. He also has chronic liver disease, and they categorise that as the Child Pugh stage B, which is a system they use to assess the prognosis of patients from A to B, and A's got the best prognosis and C's the worst. And he was hospitalised in January 2015 with ascites and encephalopathy, so he had decompensated cirrhosis. Sorry, this might be nothing to you guys now, but it's soon will when you start your documentation. So these are the medications that he was on when he came to hospital. Spironolactone, so that's a potassium-sparing diuretic for his ascites. He was on lactulose, his hepatic encephalopathy. It's got lots of different mechanisms of action, but it mainly tries to reduce the ammonium content in the blood. And then zopiclone, because he used to work night shifts, so it's to help him sleep at night. He's got no known drug allergies. No significant family history. His parents are both alive and nothing runs in his family. His smoking history was 5-pack years. He only smoked tobacco. He had quite an extensive alcohol history. He'd been drinking all his life. He said that on average he would drink a bottle of vodka and 10 lagers a day. He said he'd stopped since January, and he's seeking help from the NHS. He also mentioned that he had some periods of unemployment throughout his life, but he didn't talk a bit more about that. He was also an IV cocaine user 20 years ago, but he's had no drugs since. So more on social history. He lives alone in Clapham. He's got a family in Napier, 2 ex-wives and 3 children he doesn't see very often. And like I said, he works night shifts as a security guard. So I summarise my history now. So I spoke to a 48-year-old gentleman with a previous history of liver cirrhosis. He presented with a 24-hour history of abdominal distension, umbilical abdo pain, and some vomiting. So at this point, I'm going to go over some differentials that I would be thinking of without having examined my patient. So the first thing that comes to mind is perhaps this is a complication of cirrhosis. Is it ascites again? Maybe it's due to a carcinoma. Other things I'd be thinking of would be an obstruction, so a hernia or a stone, and they can present in similar ways, vomiting and pain. Pancreatitis, he hasn't got a fever, so that makes that unlikely. A GI bleed, but he's got no melena, he's not coughing up any blood, so vomiting any blood, so that also is unlikely as well. So now I move on to the examination. My patient was calm and comfortable at rest, but then on closer inspection of his abdomen, he had a small dressing over his umbilical area. He was also wearing compressive stockings, which all the patients have to have when they start, when they're admitted on the ward. He had tattoos on both his arms, something that's useful to note on an abdomen exam, mild jaundice, and also extensive spider nevi across his chest. I've just put some pictures in here to show you what that looked like. So you can see here the jaundice, the yellowing of the sclera, and then these are what spider nevi look like. And more than 5 is a significant number. So other significant findings included some mild hepatomegaly. But that was it. So to summarise, my patient was showing signs of underlying chronic liver disease, but the history and also the post-op dressing suggested a different cause. So now you move on and you go through some of the investigations. So I went back to when the patient was admitted from A&E. These were the bloods they took at the time. So first of all, the full blood count. The white blood cells are normal, so it's not an infective cause. He's got a low red blood cell count but high MCV. So this is a macrocytic anemia, which is common in people who have got quite an extensive alcohol history. His platelet count was low. It doesn't show anything in terms of what was going wrong at the time, but because he needed some a treatment with an operation, it's useful to note because you can't go into an operating theatre with a platelet count that low. So then you move on to the liver function tests. They all show signs of this chronic liver disease, so albumin low, and then the bilirubin, AST, and GGT are all abnormal. It's also useful to note that a stone obstruction is unlikely because the ALP is normal. And GGT is what you use to see the alcohol content in patients. So he's been abstinent for a couple of months, his is okay. But when it's very high, it's usually due to an alcoholic cirrhosis. Just something to note down. Another thing to note down is amylase is the test you use to check for pancreatitis. So my patient's amylase was normal. His C-reactive protein was being monitored, and he's cross-matched just in case he needed an operation, which he did. So the CT was done. A quick 10 seconds about what CT is. You have to imagine yourself at the end of the bed and you're looking at a cross-section of the patient. So this is the right-hand side of the patient. This is the left, this is the top, and this is the bottom. So this is a picture of the patient's abdomen, and you can see here the hernia coming out through the anterior abdominal wall. It's literally just the small intestines. And then on this side of the screen, you can see the patient's liver. It's cirrhosed, and I thought that would just be useful to show you guys. So the diagnosis was an incarcerated paraumbilical hernia, which basically means that his small bowel was being strangled by the muscles in his abdominal wall. And he also had underlying hepatic disease with some portal hypertension and ascites. But as you can see, these are both two completely different diagnoses, but they both present with abdominal distension. So then you go on to management. So the management for this patient was just to take the patient to theatre. It was done really quickly. I saw him the next day when he was just recovering on the wards, and he was going to be discharged later on that day. This is the name of the operation. So now I'm going to focus and talk a bit more about umbilical hernias. They're not the most common type. They present only in 10% of patients with symptoms including pain and pressure. And there's two types. There's a direct, which is a true umbilical hernia, and indirect. The true is a congenital defect, so my patient had an indirect one. And there's different risk factors for both. So for a direct umbilical hernia, it would be being premature, being of African descent. But an indirect hernia, which my patient had, it would be an increase in abdominal wall pressure, weak fascia. So I guess you could argue that because my patient had ascites, it made him more likely to have this umbilical hernia. And the main complication is strangulation, which unfortunately my patient had. So then you move on to treatment. You don't have to, but I chose to talk a bit about the different types of treatments. They vary depending on whether it's asymptomatic, symptomatic, if it's small or large, if it's being strangled. So in this case, my patient's, it was being strangled, so there was surgical repair, and the main complications would include a wound infection, hemorrhage, recurrence, and peritonitis. It's also interesting to know that my patient couldn't have had an elective outpatient surgery earlier because he had chronic liver disease, which are contraindications for surgery anyway. And that's what it looks like in a little kid. And as promised, these are the 8 F's or ways to remember all the different types of the distended abdomen when your consultant asks you. And these are my references. So now you look towards your consultant, he asks you some questions. Go ahead and ask me anything.
What are the important tests for cirrhosis?
What are the what?
Important tests to do for cirrhosis?
So for cirrhosis, you could do liver function tests, check the patient's clotting time, because those are all signals about how the liver's working.
And what was the patient's INR?
Normal. Otherwise, I would have noted it down. Yeah, I can't remember.
So why do patients with liver cirrhosis have a high surgical mortality?
Why did what?
Why you said that patients with liver cirrhosis have it's a contraindication for
yeah.
surgery because they have high perioperative mortality. Well, what causes that?
Ooh, I'm not sure. Is it because this is actually what happened? Is it just because their overall risk of complications is higher because they have other comorbidities like cardiovascular problems?
Well, the main comorbidity is liver cirrhosis, isn't it? That's
So what they have, like portal hypertension?
Yeah, you mentioned one of them already. So the blood test that you should have included in the presentation. INR, exactly. So they're going to have blood clotting times. If they bleed, it's going to be more difficult to correct.
Okay, fine, yeah.
This is all rehearsed, by the way. I'm not being. So this
is not rehearsed.
So this will happen. So your consultant will then try and push you on an element of the presentation.
Yeah.
And once that's done, questions will go to the floor. So the rest of the film. So any questions for Adisha, and then this can be anything. So anything you just want to find out a little bit more about the patient, because Adisha would have examined and taken history many times. Or if there was anything that she covered which you'd like to know more about, then hands up. The consultant's looking at you, expects you to Questions? Go on, Logie.
You don't have to.
I'm not rehearsing.
What's the mortality rate for a paramolecular hernia?
Ooh, low. 10%, less than 10%. Because they've changed it now to make it mesh repair, which you can sometimes even do that general.
You said last time he came into hospital he had encephalopathy. This time when you examined him, did he have metabolic flap or any symptoms of encephalopathy?
No, he didn't. He has slight jaundice still, some sightings, but no, nothing severe.
Okay.
It was a while back. That's fine. Vague recollection. Cool. So the presentation only actually lasts 10 minutes, and then people ask questions, and you get signed off for doing 2 per rotation.
Well,
I'm going to let Alex continue now.
Let's give Dita a round of applause.
Right, so Adisha got the hard job of actually doing the presentation, and I get the easy job talking about it.
So that was an example of a fairly typical grand round, a sort of quite classic case. In general, like I say, all your consultants want different things, but it should be between 8 and 15 minutes and between 10 and 20 slides. Most of them won't give you a limit. For my neurology one, I had to do a 8-minute, 10 slide presentation, which was actually quite difficult because neurology patients are always complicated, but we didn't have much time. So finding a good case is really important. And whilst some people will try and use patients they only really saw on the ward round and didn't clerk properly. Does everyone know what clerking is? I'll just explain in case you weren't at the last meeting. So basically taking a full history from the patient, doing a full examination of every system, not just the sort of system that they're presenting with, and then presenting that history and examination findings to a doctor and getting some feedback on it. So I really strongly believe you should do a grand round on a patient you've clerked in full. So you've taken the history from them yourself, you've examined every system yourself, and ideally someone you've seen on multiple occasions. So like Adisha did, you can chart their progress. You can say, well, I saw him in A&E, and then he had his hernia operation, and then the next morning, he no longer had a distended abdomen, or his jaundice was better, or his platelets had come up, or whatever. Some consultants will say they don't mind if you just make a patient up who has a classic presentation, but if it's not just a tick box and sign off, it's a really good opportunity for you to learn. And like I said last week, learning how to present a case to your colleagues is a vital skill in all of clinical medicine, so you should take the opportunity to do it well. I suggest you choose something you're interested in, a patient who had an interesting story, an interesting history, a patient who had who presented with symptoms of one thing and they actually turned out to have something else, and how that diagnosis was made, or just a patient with an interesting condition. Lots of people, some consultants like you to do, not to use patients with rare conditions and just to do the simple, typical cases, but other consultants don't mind. For one of my cases, we did someone who's had a bleed from a gastric artery after a gastric bypass, and there was no reported cases in the literature of that artery ever bleeding after gastric bypass before, so that was unusual, but it was quite interesting. And they presented with hematemesis, which is a typical thing that anyone would see around it. So you can basically do what interests you. There's no right answer when it comes to a common condition or a rare condition. Acute take, so when you're on call shadowing your firm, or when you've booked an on call on a virtual campus, is a really good place to pick up patients for grand round, because you see patients when they're quite sick, when they've come into A&E and they're being referred to the general medical team, or the general surgical team in this case. And therefore what you usually do when you see a patient on acute take is you then follow them up a couple of days or even a week or so later. So that's a really good way to go about your grand round. Say, right, well, I saw this patient in A&E, he'd come in with these symptoms, coming with crushing chest pain, and he was sweaty and hypotensive, and then I saw him 3 days later on the cardiology ward, and he had his stents put in, and he was being told to lose weight and quit smoking, and he was ready to go home. And do, like I said last week, think outside the box slightly on where you find patients. Just because you're on an abdo rotation, doesn't mean that the patient has to necessarily have come from a gastro ward. You know, you have patients with signs and symptoms from all diseases all over the hospital. So if it's relevant to any of the topics, and so Abdo is a really good example. You know, you can use a urology patient, you can use a renal patient, you can use an endocrinology patient, and there's nothing to stop you doing that, and your consultants will be hopefully will be quite open to talk about patients from other specialties, because you know, you're not here to do registrar training, you're here to do third year undergraduate medicine, so you should be looking very broad. Okay, so you saw the order of Adisha's presentation. I'll talk about that slightly. So in order to do a good grand round, you need to have the history nailed. There's nothing wrong with spending half an hour with a patient getting a thorough history and going over it and making sure you have everything right, particularly if they do have an interesting backstory. Examination, so that should be an examination of every system, at the very least cardio, respiratory, abdo, and sort of cranial nerves. You don't necessarily have to do a full neurological examination if you haven't done NOP yet and you don't really know how. But you should at least, you know, at the very least know that they have normal movements and sensation in all four limbs grossly intact. And you know, the cranial nerve should be grossly intact. And you should have learned how to do all of those examinations at your starter term block, or if not, they are in the Oxford Handbook or online very easily. So you should know their observations, and these can be at various times, and these are particularly important if you're doing any patients who have infection or have had some bleeding. You know, you really should know, okay, when they came into A&E, this patient was presenting with pneumonia, they had a temperature of 39 degrees, their respiratory rate was 32, and their blood pressure was 90/60. That's a very different patient to the same person coming into A&E who's got a stable pulse and a stable blood pressure. So you can get those from the nursing chart when you see them, and when you open out the chart, if it's not in the nursing notes, in the patient's main notes, there should be the admission sheet from A&E, and you can even go as far as, if they're coming by ambulance, they'll have the ambulance sheet in there, so you know actually when the paramedics turned up, the blood pressure was this and the pulse was this, and you can chart that through. So relevant investigations, Adisha put the CT scan up, that's imaging, but she put blood tests up. We've got ECGs for cardiac patients, ABGs for respiratory patients and those with sepsis. So your imaging, some hospitals give you access to PACS, which is the online radiology system, some don't. If they don't, if you are friendly with one of the F1s on your ward, or even one of the junior doctor registrars, and say, oh, I need to present this patient at a grand round, they'll all know what you mean, and they'll should be happy if they've got 5 minutes to find you the relevant X-rays or CT scans or MRIs or whatever. One thing Adisha did very well, and which is critical in the grand round, is talking about that diagnostic reasoning. So the same thought process, she and the doctors would have gone through in A&E, sort of like, what could this be in this man with hepatitis C and an alcohol history. So hepatocellular carcinoma, you didn't see that on CT. It was ascites, but actually, it was a sort of a local distension, not a generalised one. And then that helps you. That's the most important part, I reckon, of the grand round. Because all of these things, the history, the examination, the testing of the results, the imaging, are there to sort of drive you towards that prioritising differential diagnosis. And the treatment, did you go and see his hernia operation in theatre? No. But if you can go and see the treatment, then it's a good opportunity too, because you're going to be presenting the patient. And as Adisha said, you don't have to, but I always like to present the outcome. Grand round is about telling a story, and the story should have an ending. I like to tell the story. So I think it's always best to present your patient as a presentation than a disease, because it makes the audience a lot more interested. So Adisha's presentation started with a distended abdomen. It didn't say a paraumbilical hernia, because that kind of gives the ending away. So here are some examples about how you can phrase the title of your grand round to talk about the presentation rather than necessarily the diagnosis. So this is a good structure to start with. It's by no means the only way of doing it, it's by no means sort of the right way to do it, but you want to take this slide down, it's probably one to look at. Like I said, tell the story is the most important thing. Start with the presenting complaint, give a good full history of that, give the full past medical history of the patient, Again, Adisha did this really well. It wasn't just hepatitis C and alcoholic liver cirrhosis. It was cirrhosis at Child-Pugh stage B. It was, Hep C on Soltenzavir and all of those crazy antivirals. Like I said, drug history is really important. Social history is really important. We've got some of that as well, and family history as well. Your review of systems, and this is vital, if only to show the consultant that you didn't just go and ask them about their abdominal pain. You also make sure that you ask them about breathlessness and chest pain and headaches and all of those things. And you don't have to dwell on them until it's there, because if it's not there, the consultant will then say, well, how do you know that this abdominal pain wasn't a cardiac cause which was referred? Then you can say, oh, well, I asked about palpitations and chest pain and sweatiness and all of that, but if it's on the slides, they can't catch it out. Then investigation, examination findings, investigations, differential diagnosis, treatment outcome, and your final slide should be a teaching slide or a slide about something interesting, and that can be pretty much anything you want it to be. Adisha's was the different types of paraumbilical hernias, so you can talk a little bit more about the diagnosis. You can talk about a diagnosis that it could have been, but it wasn't, if that diagnosis is of interest to you, or if it's a particularly life-threatening or serious or unusual diagnosis. But it can be broader. If you wanted to focus on, I find hepatitis C very interesting, so I might have then talked about the different types of hepatitis C, and there's a new antiviral out which is being trialled at King's and a few other places, which is hoping to cure people of hepatitis C, which has never been done before. If I'd done this case, I might have chosen to put my teaching point about that. It doesn't have to be something that can be assessed. It doesn't have to be something which is in the textbook. And you can even go more left field if there is a particular. I remember one really good grand round I went to. The interesting point was an ethical discussion. So it was this 89-year-old lady who'd come in with metastases visible on her liver ultrasound. She'd come in with painless jaundice, which is never good. And she said, well, I don't want any more tests. I don't want to find out what the causative primary is. I just want to go home. And so the rest of the grand round was spent debating, should you let her, how should you approach this patient? Or it can be socio-economic, so it can really be anything. Like I said, it's history and systems reviews. Try and put things into the context of the patient. So, like I said, the patient can't get up the stairs anymore, and you can talk about how that progressed. So, I can say, well, my patient started becoming breathless 6 months ago, and it was, he only noticed it when he was out jogging and he had to, stop, but now he can't get up the stairs or he can't get out of the house anymore. Like I said, include a review of all the systems, not just the ones relevant to your rotation or to the patient presenting complaint. And never ever forget systemic symptoms. This applies to everything you should do, to every time you present a history to another doctor, every time you take a history of a patient, either in real life or not, you never forget to ask about weight loss, fever, and tiredness or fatigue. So when you talk about the examination, it can be very tempting if you've gone to see a patient and they have endocarditis, and you've done your reading about endocarditis, and you know that they should have Janeway lesions and these things called Osler's nodes, yeah, and a particular type of heart murmur. But actually, very rarely do patients present with every symptom in the Oxford Handbook under that particular condition. So it's really important that you say what the patient actually had, because if your consultant hasn't examined the patient herself or himself, and they probably will have done, then one of the junior doctors who's at the grand round will have done, and one of your colleagues will have done. And if you say, oh, he has this really exciting heart murmur because you know that's what people with endocarditis should have, and your consultant says, well, they don't have that, you're just making that up, and then you'll look like a bit of a tit, which you want to try and avoid. So diagrams can help get across. You'll see these sort of abbreviations if you know what they mean in medical notes. The one on the right there is, to your left, is a liver edge, a smooth liver edge, and that means some sort of crepitations. So I like to draw those out, so it makes it a bit easier than just being bullet points. So you need to give the clinical context when you give your investigations. So I like to give the normal ranges, and I'll also highlight any abnormal results in bold or in red. And certainly if the patient's been inpatient for a while, giving a trend is also a really good way to do. So most EPRs, the electronic patient record system, can produce a trend. If you don't know how, ask one of the F1s or the nurses, because they do it all the time. And then you can give a something like this. This is from a patient, which a friend of mine did a grand round on, and you can see that their bilirubin was quite high, their CRP was quite high, and then white counts were through the roof. And I think on Friday the 22nd they got their ERCP, which was the unblocking of the blocked pancreatic duct. And you see lovingly the CRP and the bilirubin and the white cells all begin to tail down as the patient recovers. And so then, when you're telling the story, that's something really good which you can show how the patient's progressed over time. So differential diagnosis, like I said, it's probably the most important part of the grand round, is what everything's been building towards. I like to list every major differential in a table and then give things which support the diagnosis and things which count against the diagnosis, and I'll rank the diagnoses from sort of most likely to least likely based on that. And even if you're seeing a patient on a ward a week after they came in, go back to the A&E notes and try and give an idea of what this process was like. It might not have been an A&E, it might have been at the acute medical ward, it might have been, after they came back from the theatre. And talk about what the thought process would have been for the people making that differential diagnosis. Like I said, this doesn't have to be their acute presentation. For example, you can do, one of mine was a patient who'd gone to theatre, and then after they came out of theatre, their blood pressure was incredibly low, and it was a case of the differential diagnosis process there was not, why had they needed to go to theatre, because we knew that was a diaphragmatic hernia, but why are they hypotensive after they come out of theatre? Is it sepsis? Is it bleeding? Is it an anaphylactic reaction? Is it some kind of anesthetic reaction? And then you can go through the same process of history, examination, and so on and so forth. And like I said, this varies in patients. It's not always going to be the A&E or acute medical unit process. It usually will be, but it might be something a patient with a suspected malignancy where the MDT has been discussing it for a long time, and there's a big meeting, the radiologist sits down and says, well, actually this is more likely because of these things, there's biopsies, or the diagnosis could be made already by the time the paramedic turns up, puts the ECG on and says, well, this is an MI. So you try and go through that process even if you're seeing the patient at a different time. So yeah, talking about the treatments and the management of patients are less important than the differential diagnosis for third year. It is often unknown, particularly if you're seeing the patient and then if you're in DGH, they've been transferred up to London and you couldn't follow them up. There are lots of reasons this can be unknown. If it is, I suggest that rather than just leaving blank, so I don't know what the outcome is for this patient, but I looked it up in Kumar and Clark, and people who present with heart failure, which is class 3, have a 2-year life expectancy. That's not necessarily true, I'm making that up, that's not expectancy for class 3 heart failure. But you can find that relevant statistic, and you can talk about that and give an idea of what the patient's outcome might be. And I like to give a list of problems. This is something that some doctors do in notes, which you might see on the wards. And that will be everything from, the very urgent thing like this patient is having a GI bleed and needs that resolved. But then I would also put lesser problems, such as the patient has abdominal pain, which needs to be controlled. The patient is anemic and may need iron tablets. And then I go down with things that are sort of like less urgency but still vital to the patient. So the patient is still drinking alcohol and will need an intervention on that case. The patient's cat is at home and there's no one looking after them. The patient's very worried about that. So you can have a list of problems which you can then sort of point to the discussion as well. Like I said, teaching points can be literally anything, as long as it's interesting. I think now I've got a couple of slides which are just examples of teaching points. So this is one of my NOP Grand Round teaching slides. I'm sorry if the slides are busy, this was the one I had a slide limit for. So I found 2 papers which look at the relationship between latitude of where you live and how likely you are to get multiple sclerosis. I've got one which says it's a very strong relationship, and the other one which says maybe it's actually due to genetics and ethnic sort of heritability rather than latitude. This one was my cardiac Grand Round, and I decided to talk about sort of emerging treatments for chronic heart failure, and I'll talk a little bit about cardiac transplants, a little bit about LVADs, just because that's something I found interesting. But, you know, I've never seen a heart transplant, certainly haven't at this stage, so it can just be something which you Google if you find it interesting. So, a few things to avoid. Whatever you do, don't try and be smarter than your consultant by picking something which you think they won't know about, because they inevitably will. I remember somebody who tried to do a sort of haematology patient when we were around Joe to try and sort of sneak it past our consultant, and he ended up being quizzed on the clotting cascade for 10 minutes. So it can backfire. It's very easy, particularly if you're doing an acute specialty, to criticise the prior management of a patient, because often these patients have interesting stories. You know, you'll say, well, actually, the GP saw them and he had breathlessness and he thought it was asthma, and now, you know, he's coming to A&E and it's obviously heart failure. But it's not good form, it's not a good habit to get into. You know, all of you will make mistakes when you try to diagnose patients. So I try to avoid it. Like I said earlier, don't embellish the history. Don't, you know, if your patient's got TB and they came in with a cough, but they weren't coughing up blood, don't add that they were coughing up blood just because you know that that's associated with TB, and you want to show that you know that. The point of a grand round is not to show off how much you know about the condition. You know, you might have a little opportunity for that when the consultant's quizzing you, and you should certainly read up on it. But you're there to present the case as it presented to you, and to give the audience a teaching opportunity to go through that process of differential diagnosis with you. If you can't get the actual ECG or the actual CT scan or the actual X-ray, you should be able to. Of course, you need to make sure it's anonymised. And with the patient permission, actually, you can use that even if it's even if you're just using a black bar over the patient's name or something. If you are going to get an example ECG off the internet because you can't find one, make sure you are open about it and say, well, I couldn't find Mr. Jones's CT scan because they wouldn't let me onto PACS. This is the CT scan I found which showed something similar, and make sure you do give credit to wherever you got it from, and make sure your learning point is brief, 1 slide, 2 maximum. I remember one of the worst Friday afternoons of my life was someone spending 15 minutes going through the NICE guidelines for the surviving sepsis campaign, and it was just atrocious, and even the consultant fell asleep. So, on that note, yeah, a brief summary. So choose something you're interested in. If you're interested in it, you'll do better at it. Follow your consultant says, even if, especially if it deviates from something we told you. Tell the story, have a good structure to it, but the story is most important. Do be ready for questions, both from your peers about, you know, you're not going to put in everything you learned about the patient into your presentation, but you know, you will get questions of interest from your peers, and be ready for a bit of debate as well. You know, there have been sometimes in grand rounds when the consultant turns around and says, well, actually, I don't think this is the correct diagnosis, and they, you know, they've gone to the ward the next day and you know, change the management of the patient. It's not a test, like I said, it's an opportunity to learn both for you and for your colleagues, and enjoy it, because they can be quite fun. You pick an interesting case and you get a bit of interesting conversation going. It can be a really enjoyable part of your field of teaching. Any questions?
So, would you choose a patient kind of as you're going along, and then or would you think about making notes, like, so you could do a grand round if you wanted to?
So the question was, should you you know, just choose a patient and think, you know, will they be good for a grand round? I'll make them notes and so every firm will do it differently. Some firm will set a rota right at the start of the week, so you'll know that, you know, in week 7 and week 2, it's your turn to do a grand round. Yeah, some firms will make you just do 1 over the whole rotation. Some will want you to do 2, so there'll be 2 people presenting every week. In some firms, like, you just have a morning of grand rounds at the end of the rotation where everybody presents it. So find out with your firm. I think most people, you get some kind of choice in it, i.e. your firm will know that on Friday one or two people has to be sorted out between yourselves. So if you have seen a patient, then yeah, just bring it forward and say, well, actually, I'd like to present this. They're usually on Fridays. Does that really make it up? No, they're not usually on Fridays. But I'd like to present this week. But if you do have someone in mind, then yeah, take those notes, make sure you have a good idea of the history and the examination and all the findings. You save their hospital number so you can go and get their investigations, and then when it's your turn, you can just use that. So it's a good thing to do if you find a good case.
Just to add to that, I've often gone up to doctors or the ward and said, do you have a patient that would be interesting for a grand round, or a patient's got interesting features? Sometimes they appear to you, sometimes you can look for them, but there's hundreds of patients in hospitals with that struggle to find them.
Oh, and if you want to practice how to do parking, just find a nurse and ask who's the best talker. That's the best way. Like all the nurses know the nicest patients who need to talk to medical students.
Yeah, and on that point, never underestimate the power of an interesting story. So our medical students, particularly third years, are obsessed, as was I, with finding the patient who has good signs or good ascites or a good heart murmur. When actually the history is a vital skill, and a patient who has an interesting presentation and an interesting life and a backstory will make just as good at their grand round as someone who has a really cool murmur, because you can't present a murmur, you can tell an interesting story. Any other questions?
So you said to examine every system with each of the patients you see, but if you haven't done that rotation yet, if you haven't done chest or abdomen, you're doing an OP, you don't need to do a grand round of it. Can you use someone else's examination findings to present those as long as you give them credit?
You should be open. You should always be open. If you didn't do an examination yourself, you should say so and say, I didn't examine this patient's neurology because I haven't done it yet. This was what was on the... all patients, when they're admitted to hospital, should have an acute medical clerking, a full clerking, which includes the examination of every system. In some specialties, in psych, it's different, because psych grand rounds are different. You'll be presenting the mental state exam, and the physical exam is something, an afterthought. Whether that's right or not is another sort of debate. Neurology will be, there'll be less focus, but that's just a side point, is if you're going to do that. Whatever rotation you've started on, and this is advice not just for grand rounds, but in general, there is no reason you can't learn every examination from junior doctors. And indeed, these first few weeks where you've got a little bit more time on your hand is probably a good way to do it. And if you'll have F1 teaching, you'll have registrars, and if they say to you, what do you want to learn? If none of you have done an abdominal examination yet, and you're on chest, you should ask to do it. And I firmly believe that when you're seeing patients, even if this is something I wish I'd done more of in my first rotation, rather than waiting until the second and third, you should, if you're going to examine a patient and present it to somebody, you should be examining every system. Now, of course, if you haven't done cardio yet, and you listen to the chest and there's a funny heart sound, fair enough, you're not going to know what that funny heart sound is. And you can say that. You can say, well, I listened to his chest and there was a funny sound, and I looked at the notes and he's got a long-standing, pansystolic murmur or whatever. But there's no real reason why you shouldn't do all of the examinations. You can be open about the fact that you might not be able to do it as well as if you had done that relevant rotation. But I'm a strong believer in doing that, purely, and not just for the fact that it improves the integrity of your presentation, but it's the right way to do things. It's a good habit to get into, and it's more practice of examinations before you need to get to the stage where you're actually going to be assessed. So that's my personal point of view. Very nod, shake.
I don't have an answer from the
Yeah. Okay.
Any other questions?
No? Fantastic. Thank you very much for coming. Brian says to tell you that you're all going to be this weekend. Oh, and there's still